Went in for a routine checkup, had a blood test, and I got a call that night saying to come back and retake it because the results were a little funny. And a week after the test, that's when they said that I had CML.
I'll never forget talking to the doctor, and he said, well, you're gonna need this bone marrow aspiration. That's one way I can really tell what's going on. And I'll never forget he was turning away from me, working at his desk, and I said, Doc, is this gonna kill me? And he just looked at me and goes, I don't know yet.
Well, I started working on the disease chronic myeloid leukemia, or CML, in about 1990. In 1993, when I moved to Oregon Health Sciences University, I contacted Nick Leiden at Sivagagi. They developed some very specific inhibitors, but we're now looking for somebody to test them in various model systems. He sent me the best of their compounds. I identified one of them that specifically killed CML cells without harming normal cells.
I guess they can't say it's completely cured, but I know my last PCR scans for the last 2 years, at least, there's been no sign of Philadelphia chromosome at all.
People forget, like friends and family, they forget that I'm sick, right? They forget that I have cancer because I don't look, or, you know, like what people might probably expect what a cancer patient's gonna look like, or you know, or present themselves as.
In October of 2008, I was diagnosed with metastatic breast cancer. My breast cancer was HER2 new. As a result of that, most of my therapies have been targeted, pretty much targeted therapies related to the HER2 new.
Well, the whole concept behind understanding that there was a subtype of breast cancer called HER2 just came from observing that there's clinical variability in the outcomes for patients with breast cancer. And then we started to study those breast cancers genetically, looking at the DNA and the RNA, and found the HER2 alteration in about 1/3 of breast cancers. That 1/3 of patients had a much different outcome, a much more aggressive subtype of breast cancer. We then sort of said, why is it associated with a bad outcome? Either it's a marker for it, or it's associated with it because it's playing a role in causing that. So that led to the laboratory studies that we did, where we put the HER2 alteration into breast cancer cells that didn't have it. And then we saw that their behavior changed dramatically. And that was the time when we really realized we may have something. We may have a target that we could go after.
I've had to retool my expectations. I don't put as much money in my 401k, for example. I do tend to live more in the present. I've chosen to live and try to make sure I maximize my quality of life and move forward.
Elizabeth was diagnosed with stage 2 high-risk neuroblastoma with amplified NMEC.
The Children's Oncology Group ran a pivotal study where we combined an immunotherapeutic approach, taking advantage of this excessive expression of GD2 on neuroblastoma, and showed that that approach provided, after children have received chemotherapy and radiation therapy, so when they were in their first remission, that using immunotherapy in that situation improved survival 20%. And that is about as much of a home run as you can expect in a large randomized phase 3 clinical trial, and something that overnight changed the way that we approach the disease and has led to the implementation of immunotherapy as now a standard way to treat neuroblastoma to improve survival by preventing relapse.
I believe absolutely that she is here today and we are able to live our lives because of cancer research, and that it saved her life.
The major challenges immediately right now, of course, is funding. Funding is becoming very limited, as you know, due to a number of economic issues.
Over the last decade, we've seen an emergence of provocative insights into how the immune system both facilitates tumor progression as well as impeding effectiveness of some of our best chemotherapies. And what research is saying today is that we can use that to our benefit by harnessing the power of the immune response to make chemotherapeutics do a better job.
We will continue to understand the most basic things about cancer cells and be able to transform them quickly into clinical application.
Genomics has taught us a great deal about the fact that epigenetic regulation, which means regulation of proteins that wrap chromatin and unwrap chromatin and allow it to be read and translated, transcribed, That is now becoming a hugely important area. We don't really understand exactly how changes in chromatin structure affect biology in response to treatment, but it's very clear that that's going to be an area that we need to understand.
Good translational clinical trials that will hopefully take that science, bring it into the clinic, and hopefully help answer those questions and make that difference, hopefully for the patients that we're treating, but equally, as not more importantly, for their children and our children and the future of cancer patients.
I always say that right now in cancer research, we're sort of like what Winston Churchill said about World War II, which we're sort of at the end of the beginning, but I really think that we can see the beginning of the end. I view a future in which we have very precise molecular diagnosis of all tumors. We then use a combination of targeted agents, targeted radiation, targeted surgery, and immunotherapy possibly combined to affect durable cures for cancer. That's what I see.